welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today I am taking you all to explore the world of rare diseases. And my topic for today is Budd Chiari Syndrome. To give us an in-depth knowledge of the syndrome, we have with us today Dr. Shrihari Anikhindi, who is an associate consultant at the Institute of Liver Gastroenterology and Pancreatico-Biliary Sciences at Sir Gangaram Hospital, Delhi. So, welcome to Medical Dialogue, sir. It's really a pleasure to be interviewing you here today.
Thank you so much. It's my pleasure to be on board.
Great. So if you could just provide us an overview of what the syndrome is, talking about how rare this syndrome is, and if you could also cumulatively tell us about its causes, symptoms, and its risk factors that one should be aware of.
So basically, Budd Chiari Syndrome, as we call it, it's a rare disorder. It's a rare disorder, and the estimated prevalence is somewhere between 1 in 50,000 to 1 in 1 lakh cases. So out of 50,000 normal people, you will be having one case of Budd Chiari, and this prevalence varies according to regions, and in some parts of Asia this is thought to be more common. It is usually seen in the age group of around 35 to 40 years, that is in the third or the fourth decade of life, and it is seen equally in both the male and female sexes. Now, to understand what is Budd Chiari syndrome, so you see, liver is a very major organ of the body, and liver receives its blood supply from a portal vein and hepatic artery, and its venous drainage. So that's something that goes out of the liver, the toxins or the blood which goes out of the liver is through the hepatic veins. So Budd Chiari is basically a condition where there is an obstruction, or there is a thrombosis, or there is a blockage of these hepatic veins. So basically there are three hepatic veins, that is the right hepatic vein, the middle hepatic vein, and the left hepatic vein. Budd Chiari usually leads to symptoms when there is obstruction of at least 2 out of 3 hepatic veins. So the causes are varied. There are several causes to Budd Chiari syndrome, but most of these patients with Budd Chiari syndrome usually have an underlying disorder of hypercoagulability. That is, the blood becomes too thick, it becomes very thrombotic, and in around 75% of the patients with Budd Chiari syndrome, we have some hypercoagulable condition. Okay, and in 1/3 of these patients, there are more than one prothrombotic conditions that are present. So the most common prothrombotic conditions are myeloproliferative disorders, antiphospholipid antibody syndrome, paroxysmal nocturnal hemoglobinuria, conditions like factor V Leiden deficiency, protein C deficiency, protein S deficiency, antithrombin deficiency. If you talk of the more commoner things, so this can be seen in certain patients with pregnancy, in people who have been taking oral contraceptive pills, or in certain inflammatory conditions of the abdomen. So these are the things which are causes for Budd Chiari syndrome, and the same disorders are also risk factors. So patients who are suffering from these disorders are at a risk of developing Budd Chiari syndrome in their lifetime. So what are the symptoms of Budd Chiari syndrome? So basically what is happening in Budd Chiari syndrome is basically there is an obstruction to the hepatic vein, but the body has its own defense mechanisms, and there would be a tendency to overcome this obstruction through certain defense mechanisms. So the symptoms all depend on how fast is the blockage occurring. Are there any compensatory mechanisms occurring in the body to take care of this obstruction? So if the obstruction is very rapid, very fast, and the body is just caught unawares, it could lead to a fulminant kind of a picture where there is a catastrophic derangement of the liver function, and these patients usually present with acute onset abdominal pain. So this is the fulminant form. There is also an acute form where the progression is slightly slower, the obstruction is not very rapid, and there is some collateral flow that is occurring. So in these patients, usually the presentation is more of an abdominal pain, and it is usually associated with jaundice. The third type of presentation is a chronic presentation, where the obstruction has occurred, but the obstruction is occurring at a slower pace, and there is some collateral flow formation which is occurring, and because of this, the patients would usually present with symptoms of chronic liver disease like ascites, hepatic encephalopathy, and some presence of collaterals, that is these dilated veins that you can see on the abdomen. In 15% of the patients, the Budd Chiari syndrome tends to be asymptomatic. That is, though there is an obstruction to the hepatic veins, there are no symptoms because there are good collateral vein formation which has occurred in the body, and this is helping to provide the adequate blood supply and outflow from the liver, and that does not lead to any of these.
Great. So that was actually a very good explanation of how it is considered to be a rare disease and what symptoms one should actually look out for. Now, coming to the next aspect, you explained to us its causes, Budd Chiari syndrome, the symptoms, and also the risk factors you mentioned. Coming to the diagnosis aspect of it, how do you think that the Budd Chiari syndrome is diagnosed, and what are the typically diagnostic tests that have been conducted to actually confirm the condition?
So when we talk of diagnosis, first you need to have a doubt whether this patient is actually suffering from Budd Chiari syndrome, because often the presentation is something very similar to a liver cirrhosis patient. So the patient is just presenting with ascites or jaundice. So there needs to be a doubt in the mind of the treating physician that this could be Budd Chiari syndrome, and usually these patients are those patients who have presented with a sudden onset of ascites, that is fluid in the abdomen, or sudden onset of jaundice, but rest of the liver parameters look okay. There are no other signs of portal hypertension as such, and the platelet counts tend to be normal. This is in contradiction to what is normally seen in patients with liver cirrhosis. So if you have such a patient, there is a suspicion of Budd Chiari syndrome. So for diagnosis of Budd Chiari syndrome, you have the classical imaging modalities which help you prove the diagnosis. Apart from that, there are ancillary tests. So these are the tests which we usually do and which can arouse a suspicion of Budd Chiari syndrome. So if you have done a hemogram, you would see that the platelet counts might be slightly low, or they are usually normal. The hemoglobin tends to be slightly on the lower side. In patients with acute fulminant Budd Chiari syndrome, the liver function test would show a significant rise in the liver enzymes, that is the SGOT and the SGPT. If it's a chronic Budd Chiari syndrome, the enzymes tend to be normal, but there is some derangement in the bilirubin levels and in the albumin levels. Usually these patients with chronic Budd Chiari syndrome present with ascites, and when you do an ascitic analysis in these patients, you see that the ascites is high SAG, that is high serum albumin ascitic gradient, and it is also high protein. So high protein is the total protein is more than 2.5 grams in the fluid. So this is different from the conventional patients of liver cirrhosis related ascites, where the patients have high SAG but the protein content is not that high. So once you have these ancillary investigations and you have this doubt of Budd Chiari syndrome, so usually would go for some imaging modality. So the most common imaging modality used is an ultrasound because it is very widely available. It helps you in treatment planning and follow-up after intervention, and it has a very good sensitivity and specificity to the tune of 85%. You need to use a Doppler when you're doing an ultrasound because you need to see the flow in the hepatic veins. The limitation of an ultrasound is that it is often very operator dependent, and you need to have a good amount of experience when you're dealing with diagnosis of Budd Chiari syndrome. Patients with obesity also, the ultrasound might not be very optimal because the ultrasound waves might not be able to penetrate the thick skin. So on an ultrasound Doppler, what you would usually see is there is an absence of flow in the hepatic veins. You can very often see intrahepatic coma-shaped collaterals which are very pathognomic of Budd Chiari syndrome. There are usually subcapsular collaterals which is not usually seen in other liver diseases. The caudate vein is usually dilated. The caudate lobe is hypertrophied. This is again one very characteristic feature of Budd Chiari syndrome. In patients who have obstruction in the IVC, you would see some functional narrowing in the IVC, and there are some accessory collaterals that are usually seen. Other imaging modalities are MRI. So in MRI and a CT scan. So MRI, you would see in an acute Budd Chiari syndrome, you would see global liver enlargement, a caudate lobe hypertrophy, divergent signal intensities, and contrast enhancement in the periphery as compared to the center. In chronic Budd Chiari syndrome, you would see heterogeneous signal intensity in the left lobe and the caudate lobe of the liver on an MRI. A triple phase CT, that is a CT scan with a triple phase contrast, is also very, very good modality for diagnosis and confirmation of Budd Chiari syndrome. It is especially useful when you need to do or when you plan for a interventional procedure called like TIPS, where it helps you delineate the venous anatomy in greater detail. In a patient with Budd Chiari syndrome, on a CT scan, you will see a fan-shaped enhancement, and this is because of a reversal of the portal venous flow. And you will see some patchy enhancement in chronic Budd Chiari syndrome with some nodular nodules in the liver. These are because of hyperattenuation in the arterial phase, and this remain same in the portal phase with no washout. There are other tests also, like a hepatic venography or a liver biopsy, which is not usually required, and it's usually done in very, very rare cases for confirmation of diagnosis.
Okay, so sir, if I just have to talk about it in a nutshell about the diagnostic aspect, so it's basically an ultrasound, which will be the primary step for diagnosis of Budd Chiari syndrome. That is, as you mentioned, it is easily available, so it can be easily diagnosed also, at least in the first stage.
So most often than not, it is the ultrasound which comes to your rescue, and it helps in diagnosis of Budd Chiari. You need to do an ultrasound with a Doppler, and you need to be very keen when you're doing an ultrasound to diagnose a Budd Chiari. So it needs a certain amount of expertise. When you go to the next stage of planning the treatment, you need these further investigations like an MRI or a CT scan. But more often than not, the ultrasound would help you pick up the diagnosis.
Great. So now coming to the treatment aspect of it, what are the treatment options that are available for Budd Chiari syndrome, and how is the choice of the treatment that is actually determined? Are there any parameters that one has to look out for when we have to divide the treatment options for treating this syndromic patients?
So for treatment of Budd Chiari syndrome, there are certain general principles that come into play. So first and foremost, it is very important that if the patient is presenting with acute fulminant Budd Chiari syndrome, you have to intervene early. You have to make sure by that with something or the other, you need to open up the blocked hepatic veins. That is an emergency. Okay. So if this is not acute, this is a chronic condition, then you are not in that much of a rush to open this, and you do a supportive treatment in such cases. So supportive treatment starts with treating the underlying cause. The underlying cause means the various hypercoagulable things, the disorders that we discussed about. You need to treat them, and you also need to run a supportive or a symptomatic treatment. That is, if the patient is having ascites, you give him diuretics. You do a large volume paracentesis. If the patient has developed esophageal varices because of the portal hypertension, you need to do an endoscopic variceal ligation. And so this forms a part of the general principle of treatment. If you talk of the specifics, so the specific treatment includes a medical management, an interventional radiology guided management, or a surgical management. So the medical management involves anticoagulants, like using a unfractionated or a low molecular weight heparin, or vitamin K antagonists, or nowadays directly acting oral anticoagulants are also used. So if the patient has a thrombophilic state, usually these patients would be on lifelong anticoagulation. Thrombolysis is an option if the patient has presented to you in the acute stage, that is within 72 hours, and that is a golden period. And if the patient has presented within 72 hours, there is an option of thrombolysis, and you can do that by either using a urokinase or a tissue plasminogen activator. There are certain contraindications to the use of anticoagulation and thrombolytics, like any bleeding disorders, any cerebrovascular accident in the past, or uncontrolled blood pressure. So then after this, if this is not helping you, there are options of endovascular radiological interventions like angioplasty or stenting. So angioplasty is basically a balloon dilatation of the stricture. The problem with angioplasty is that there is a tendency for recurrence of failure. So nowadays it is seen that the stenting works better. So you stent the obstructed vein using a stent, and this is shown to have a 90% patency rate at around 3 years. So if the endovascular interventional radiological options fail, then you have an option of doing a TIPS. So TIPS is like placing in an artificial stent between the hepatic vein and the right side of your portal vein. So it is often used as a rescue therapy, or it is also sometimes used as a treatment of choice if the patient has presented in a fulminant state with progressive liver failure, when the obstruction is no longer amenable to angioplasty, or if the thrombolysis has failed. If the IVC is occluded, if the inferior vena cava is occluded, or the portal vein is completely occluded, this might not respond to thrombolysis. You need to go in for a TIPS. Also in patients who have refractory gastrointestinal bleedings because of severe portal hypertension, or refractory ascites. So this is when TIPS comes to play. The TIPS can also be used as a bridge to liver transplant. So very often these patients might require a liver transplant and the liver is failing, and the TIPS buys you time. Okay. So if TIPS is not an option, then you have to think of surgery. So there are two types of surgeries. One is a non-shunt surgery, that is doing a membrane resection or a IVC reconstruction, and there are shunt surgeries. There are different kind of shunt surgeries that are available. That is a mesocaval shunt or a mesoatrial shunt or a cavoatrial shunt. In some patients, you have to go in for liver transplantation, especially if the patient is having a fulminant hepatic failure when there is an hyperacute presentation, or the cirrhosis is already established in chronic forms and it has led to a very advanced stage of cirrhosis where the patient is decompensating again and again, or if there is a failed angioplasty or a failed TIPS procedure. So usually there is a stepwise approach to treatment. So the supportive care is present in everybody, where you deal with the complications in real time. You give the anticoagulation in all these patients who have this obstruction and who have these underlying hypercoagulable disorders. Anticoagulation doesn't help, you go in for a thrombolysis or an angioplasty. Doesn't help, TIPS is an option. Doesn't help, surgical shunts is an option. And the last is a liver transplantation, which is reserved, or which is an option present in a small subset of the patients.
That's very well explained, sir. The treatment options, the stage wise, as management, medical management, and then lastly coming to surgical management and then transplantation. Now coming to discuss the role of lifestyle. Now, what do you feel would be the lifestyle changes or any dietary modifications that are recommended for individuals living with this syndrome? Are there any specifications that one has to take into account?
So lifestyle might come into play when we are dealing with chronic Budd Chiari patients. So chronic Budd Chiari patients would have eventually developed some amount of cirrhosis, and in these patients the lifestyle measures are same that we recommend to patients with cirrhosis. So the most important measures that we usually ask these patients to do is to restrict the amount of salt intake. That is the most important, because the more salt you intake you have, the more sodium goes in, and that leads to fluid retention. So managing the fluid retention with and managing the ascites becomes a huge challenge in such patients. You also encourage these patients to have a higher protein intake, because usually these patients land up with sarcopenia and muscle cachexia. So they need to have a good amount of nutrition, a healthy diet in general. And so these are basically recommendations for the chronic phase. In acute phase, it's a very fulminant disease, and these patients usually would not do well with lifestyle, but they need some intensive medical intervention or a surgical or a radiological intervention to get better.
Okay, that's well explained, sir. Now, next aspect is talking about the prognosis aspect of Budd Chiari syndrome. So, if you could just discuss the prognosis of it and the long-term outlook for patients who are specifically those who are receiving treatment.
Okay, so Budd Chiari is one of these conditions where early diagnosis is extremely essential, because your prognosis actually depends on how early the disease has been diagnosed and has it been treated in time before the complications have set in. So unless treated, if the patient is not treated, the natural course of the disease is extremely severe, and less than 10% of the patients will survive for more than 3 years without any treatment. So if the treatment is made timely and right interventions have been initiated, the survival rate is more than 90% at 5 years. So there's a dramatic difference between not doing things in time and doing things in time. So the long-term prognosis depends on how much of the disease is already set in before you start the treatment. So there are some risk factors which tell you whether the prognosis would be good or bad. So the factors which lead to good prognosis are usually patients who are younger in age, patients who have a low Child-Pugh score, that is the livers are doing well, the creatinine levels are low, and there is an absence of ascites. Bad prognosis, or the outcomes might not be very good if all the three hepatic veins and or the portal vein is involved, if there is presence of ascites, if the age at presentation is at an elderly age group, if the Child-Pugh score is very high, or if the chronicity is already established and the patient is already having a decompensated liver disease.
Understood. Now, lastly, Dr. Shrihari, if you could just explain to us, if you could just give us insights on, are there any ongoing research efforts or any clinical trials that are ongoing that are basically aiming to improve the diagnosis as well as the treatment aspect of Budd Chiari syndrome?
So one of the most important areas where work is being done in alleviating or reducing the incidence or making the diagnosis and treatment better is having a better understanding of the molecular pathways that are underlying these thrombophilic conditions which are implicated in the pathogenesis of Budd Chiari. Because once Budd Chiari happens, your treatment remains the same. So we need to understand what leads to these thrombophilic conditions so that we can preemptively manage these. Also, there is a lot of work going on in the role of genotyping and gene mutations which determine the coagulation status in patients with Budd Chiari. And as of now, we are not very certain of the exact criteria that needs to be used or the exact prognostic indices that need to be used to stratify the patients to determine which patient will do well with what kind of treatment. So we still need to have some better criteria and prognostic indices that help us segregate these patients better and that help us giving a better option of treatment at those particular stages. So I think these are the 2 or 3 places where work is going on, and in very likely in the coming future we might be having better answers to these questions.
Great. So thank you so much for joining us today, Dr. Shrihari. It was lovely to be interviewing you and gaining all the insights on Budd Chiari syndrome, and considering how rare it is, and all comes down to early diagnosis and better treatment. So thank you so much for joining us today at Medical Dialogues.
Thank you so much. It was a pleasure. Thank you so much.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.